Okay. Okay, we will get started. Welcome to the opioid exposure during pregnancy and the postpartum period, presented by Dr. Shona Ray-Griffith. This free educational event is brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadiana Area Human Service District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for prevention and treatment of opioid use, misuse, and abuse. For more information on future presentations in this series, please visit womensfoundation.com/COS. This session is accredited for 1 hour for social workers, licensed professional counselors, ADRA, AMA, PRA Category 1 credits. Full participation of this presentation is required to receive credit and will be monitored throughout the session. After the event, you'll receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Financial disclosures. Dr. Shona Ray-Griffith has financial disclosures with Sage Therapeutics and Neuronetics. These financial relationships do not impact her presentation. Dr. Shona Ray-Griffith is an assistant professor in the departments of psychiatry and obstetrics and gynecology at the University of Arkansas for Medical Sciences. She is board certified in both psychiatry and addiction medicine. Dr. Ray serves as a current ambulatory director of the Women's Mental Health Program, as well as the program director of the Addiction Medicine Fellowship. Her clinical expertise includes the management of mental illness, substance use disorders, and chronic pain throughout pregnancy and the postpartum period. So I will introduce to you Dr. Shona Ray-Griffith, and if you have any questions, please type in the chat or the Q&A, and we'll answer that at the end of the presentation. Welcome.
All righty. Good morning, everyone. Good afternoon. I guess we're more than halfway through the day. So I am going to share my.
Dr. Griffith, I don't think we can't hear you.
Can you hear me now?
I can.
Okay.
I can too.
Okay. I'll say it was working. I didn't do anything differently. But Ashley's still shaking her head like she can't hear me.
Okay, we can hear you.
Okay. Okay.
We can hear you.
All right.
Sorry about that.
It's okay. I am going to share my screen, I believe, and get in presentation mode. There we go. And so I am going to talk about opioid use disorder in pregnancy and the postpartum period. And thank you for that introduction. I think it sums up what I do on a daily basis. I am a women's mental health provider. So my first expertise is psychiatric care of pregnant and postpartum women. And then what I do a couple days a week is actually focus on substance use disorders, which include opioid use disorder. I have received clinical trial support from Neuronetics and Sage Therapeutics, but neither one of those will be discussed here. And if you have any questions about either one of those, I would be glad to answer. So what are we going to accomplish today? Well, we're going to talk about what is the problem of opioid exposure in pregnancy. Do pregnant women take opioids? Do they use opioids? And do they have opioid use disorder in pregnancy? Then we're going to talk about, well, what does that do for the pregnant woman, as well as what does that do for the baby during pregnancy as well as afterwards? Then we're going to talk about patients when they come in, and what they look like, as well as how to treat that. So what do we do when we actually manage opioid use disorder in a clinical setting? I also have some slides if we get to the end where we can talk about a recent study that we did that has been submitted for publication about the impact of COVID-19 on pregnant women with opioid use disorder. So when we look at opioid use disorder, we first say, well, do people use illicit substances during pregnancy? Well, of course not, right? Pregnant women do everything that they're supposed to, include exercising, eating, riding, sleeping enough. Well, not exactly. So this is data from SAMHSA, the Substance Abuse and Mental Health Service Agency. And this data is about 10 years old. I have more recent data in the next slide, but from 2010, what we see is we have, this is substances down here on the bottom line. We have illicit substances alcohol, binging alcohol, and then cigarette use. And then we also have this broken down by age. So the light blue right here is teenage pregnancies. The red is ages 18 to 25, and then the green are ages 26 to 44. And what we can notice from this study and this graph and this data is, one, as women get older in their pregnancy, their use decreases of all substances. We also see that teen pregnancies, the blue lines here, actually have the highest rate in almost all categories except for cigarettes, where they're almost tied with women ages 18 to 25. We also notice in this that cigarettes are still by far the most common substance use among women. So tobacco exposure is still the most common. So when we further get down to illicit drugs and opioid use, we have more recent data, and this is data from 2015 in blue. Orange is 2016 data, and this brown color is 2017. This is the same survey done by the same people, just done at later years. And what you'll see is from 2015 to 2017 here in illicit drug use, that use is still increasing. In fact, in 2015, 4.7% of pregnant women admitted to illicit drug use in the past month. 2 years later, it nearly doubled to 8.5% of illicit drug use. Now, who is driving and what is driving that doubling? The majority of the doubling is driven from marijuana and opioids. In fact, in 2015, this is 3.4% of pregnant women admitted to marijuana use. 2 years later, that nearly doubled to 7.1%. For opioids, we had 0.8%, so less than 1%. And then later on, 2 years later, it went from 0.8% to 1.4% 2 years later. So almost just a slight under doubling of that percentage. Again, here we still see tobacco and alcohol are far more common than the use of other illicit drugs. What other studies do we know? So that's one. So we know women who are surveyed and they admit to illicit drug use. The other data that shows us that illicit substances or opioids are used during pregnancy come from larger database studies. So there are two studies, one done in 2007 and one done over 2005 and 2011. That looked at prescription databases. So they look at a cohort of pregnant women with Medicaid and who filled opioid prescriptions during 2007. And the first study found that of pregnant women with Medicaid in this cohort, that over 1 in 4 women filled a single opioid prescription during the pregnancy. And that is pretty high, that 1 in 4 women get it during pregnancy. This is not at delivery because of a C-section or a vaginal delivery. This is actually during their pregnancy. Some more data that actually looked over extended periods of time from 2005 to 2011, and that looked at commercially insured populations, found that this number was slightly lower at 14.4%. And this last study actually looked by state. And by state, they looked at the percentage of individuals. And where I am, right here in the middle of Arkansas, we were actually one of the top 3 states for opioid use during pregnancy. And if I go down south to the boot here to Louisiana, y'all are second. Y'all are just underneath us at about somewhere between 16.6 to 20%. So somewhere around 1 in 5 pregnant women get a prescription for opioids or less than that. So still pretty common there in Louisiana as well, but y'all are doing better than my current state of Arkansas. The other data that we get for opioid use in pregnancy is we can look at the rates of NAS, or what is known as neonatal abstinence syndrome. This is also called neonatal opioid withdrawal syndrome. And this is something that is seen in infants that are exposed to opioids and other types of illicit substances and some prescription medicines in utero. And shortly after birth, usually between 3 and 5 days after delivery, they start showing signs of what many people will refer to as withdrawal. But it's a constellation of symptoms, and we'll get to what that is here in a little bit later on in the presentation. But we can look at the rates of NAS or NOWS NOWs that we see over time. And that's another indicator of opioid use in pregnancy. And this is national data from the CDC. And they show that in 2000, the rate of NAS per 1,000 deliveries was about 1 in 1,000. And if you look over here, 14 years later, that number is closer to 6.5 per 1,000 delivery. So it is increasing dramatically in the past 14 years. What does it look like in Louisiana? I went and found this data off the CDC, off the AHRQ database. I had to go looking for it because I wanted it relevant to you guys down in Louisiana. And where are you guys? And this is the only, other than the study that I showed you that looked by states of commercially insured population, this was the other study I found that actually looked at Louisiana. And here your rates of NAS in 2017 per 1,000 newborn hospitalizations was 5.5 to 7.6 births per 1,000. So that leaves you not at the highest group, as such as Tennessee, Kentucky, West Virginia. The Appalachian Mountain states tend to have the highest rates of NAS, but you're also not the lowest either, such as Texas or California. You're somewhere a little bit above the average on your rates of NAS. So this is another indicator of opioid use exposure in pregnancy. Now, we look at, so we know that opioid exposure occurs in pregnancy. We know that from data showing illicit drug use. We know that from data of prescription opioids. We also know that from rates of NAS or NOWS at delivery. But what does that mean? So why do we care about opioids in pregnancy? Well, one, we know that they have, or we get concerned about the adverse effects of how these drugs will have on pregnancy. And that can start with miscarriage rates, to birth defects, to actually the impacts on pregnancy. And for those of you who are not familiar with many of these terms, do not worry. That's not the purpose of this presentation, and I don't want you to have to get too bogged down in the weeds over here. But LBW is low birth weight. PROM is premature rupture of membranes. That's your water breaking early. IUGR is intrauterine growth restriction. So that's the baby is not growing as the baby should, or there's not room in the placenta for the baby to obtain the appropriate length, height, and weight. But what I want you to notice here is this is the data that we know about the exposure of medications and their impacts on pregnancy. And you'll notice up here we have tobacco and we have alcohol, and then we have other commonly illicit drug use that we look at. And you'll actually go back to thinking, well, you know, you kind of grew up hearing about cocaine babies or crack babies, but we actually did years of research on that. And when it actually came down to it, after years and millions of dollars researching what you call crack babies, there actually was not, the data did not support the term crack baby, nor did it support many adverse effects on pregnancy. Okay, so you'll see here, there were not many adverse effects on pregnancy at all, other than increased rates of miscarriage, increased risk of fetal morbidity early on, but no other really adverse effects of pregnancy. That being said, with opioids, we got a little bit more data here. But the overwhelming data still supports that tobacco and alcohol use in pregnancy still has more adverse and negative effects for the mom and the baby long term than any of the commonly illicit substances that we use. But yet, patients still use tobacco during pregnancy. It's more common than alcohol, and it's also more common than other illicit drug use. So these still are the biggest concerns when it comes to a pregnant woman using substances. These are still more concerning than the others. Although they're all concerning, the negative effects here are still greater for tobacco and alcohol. So when we narrow down to opioid use, what do we find out about opioid use in pregnancy and negative outcomes? The majority of this data for opioid use in pregnancy and its impact on pregnancy and the baby come from studies done with methadone for opioid use disorder or for patients who are getting treatment for opioid use disorder. Very little of this information comes from patients who are getting prescription opioids from chronic pain or for other reasons. First, we know women with opioid use disorder do not get adequate prenatal care. They get late prenatal care or they do not attend all of their appointments. We also know that women with opioid use disorder do not take care of themselves. They don't eat right. They don't sleep. If they're actively using, they may be exposing themselves to sexually transmitted diseases, violence, or even legal consequences such as incarceration, which impacts their ability to get both proper obstetrical care as well as proper treatment for their substance use disorder. In turn, if you're not taking care of yourself as a pregnant woman, then you're also not taking care of your baby. Patients with opioid use in utero are also at an increased risk of placental abruption, which is when the placenta starts to separate from the abdomen too early, as well as preterm labor. So having a baby before or having labor before 37 weeks of gestation or 37 weeks of pregnancy. Now, the number one is everyone wants to know, well, do opioids cause birth defects? Well, overall, many people will tell you no, but the evidence is still not there to 100% say that. There was one study, a very large study done that showed an increased risk of cardiac defects with first trimester exposure. And then another study did not repeat and find that there was a presence of cardiac defects, but they did find an increased risk of neural tube defects. So many people will say, well, we don't really know if opioid use causes increased risk of birth defects, but overall, your relative risk of a birth defect is very low with an opioid use in pregnancy or without. The other thing we know with opioid use in pregnancy is that there is an increased risk of fetal growth restriction, which again is the baby's not growing to their expected potential while in the belly, as well as increased risk of fetal death. And most of that is seen with first trimester use, and most of that data is related to heroin use back from the 1970s, and heroin withdrawal was associated with some reports of fetal death. We do not think increased risk of fetal death with the more recent prescription opioid use epidemic that we have been seeing is much of a concern. However, I'm sure it is the same in Louisiana as it is here. The prescription opioids have largely been replaced by heroin, which has been largely replaced by fentanyl here. And so it is possible that we could see this if we were to look at these studies now, but I am unaware of any studies that have looked back at that with the current fentanyl use that we're seeing. So what about later on? What about as the child grows and the child is becomes, school age or even a teenager? Well, one, we have really limited data. Very few studies have followed babies who were exposed to opioids in mom's belly later on in life. We do have one study that did follow them up to 5 years of age and looked at their cognitive development, so their IQ, found no significant differences. Right now, we at UAMS are part of a larger study that is actually doing this. We are enrolling moms who have opioid use disorder and are getting Suboxone in pregnancy or buprenorphine in pregnancy and following them out as well as the children out long term. And they are getting imaging of their brains as well. So this data is currently being collected, but it's going to be a while before we get there and we know this answer. Also, when we look at the impact of opioid use and in pregnancy as well as on babies as well as on children, the data is often confounded. We know that people who use opioids rarely just use opioids among themselves. 80%, if not more, smoke cigarettes. We have a large problem here in Arkansas with methamphetamines as well as marijuana use. So you can't just look at the effects of opioids. You're really looking at the effects of opioids, cannabis, and methamphetamines on many of these children. You also have the environment and the genetic factors as well as other medical risk factors. So if there were any negative pregnancy effects on such as preterm labor and preterm delivery, you also have those that play into later infant and child outcomes. So what do we do as a medical profession, or what do we do as the medical profession to help these individuals? Well, the American College of Obstetrics and Gynecology recommends that every pregnant woman at their first OB visit, as well as during each trimester and the first postpartum visit, is screened for illicit substance use. And they recommend using SPIRT, which if many of you are plugged in here, I'm sure it's because you work in the area of substance use disorder, so you probably have heard SPIRT before and you're very familiar with it. And this just stands for the S is screening, BI is brief intervention, and RT is referral to treatment. So they want you to screen these individuals, and they want to do that by just a variable screening tool. And they want you to use a validated one. I'll show you some examples here in a few minutes. The 4 Ps, the Not a Quick Screen or CRAFT. They do not recommend the use of a urine drug screen. And we're going to talk about that here in a minute about why that's important and why that is not recommended. Then, if the patient is positive, they recommend that you provide feedback and advice on the impact of substance use on pregnancy, and then you offer the patient a referral to treatment. It's very important to do this non-judgmentally. Many women actually present to my outpatient clinic prior to initiating obstetrical care because they want to say, I'm getting treatment and I am already addressing this issue before they go to their obstetrical provider because of the fear of retaliation or judgment by the providers. So it's very important to do this in a non-judgmental, caring, open way, as well as to do it multiple times during pregnancy. So not just that first visit, but once you've developed rapport with the patient. So each, resulting trimester, because you never know when they will open up to you or when they're ready to receive care and admit to it. So the two things that are there's 2 screening tools I'm going to mention real quick. One is the 4Ps has been validated in pregnant populations. And this is simple. It's parents, partner, past, and present. So do any of your parents have a problem with drugs or alcohol? Does your partner? And then in the past, have you had a problem? Or in the past month, have you drank any alcohol or used any drugs? And if they answer yes to any of this, you should follow up with more questions about potential illicit substance use. The other one that is recommended for use in individuals under the age of 26 is CRAFT. And the CRAFT stands for car, relax, alone, forget, family or friends, and then trouble. So have you ever ridden in a car driven by someone who was high, or have you ever driven a car when you were high or intoxicated? Do you ever use alcohol or drugs to relax? Do you ever use alcohol or drugs when you're alone? Do you ever forget things? Do your family and friends ever express concern about your drinking or drug use? And then have you ever gotten in trouble while you were using alcohol and drugs? And 2 or more positive items need further assessment. And again, this is really helpful for those individuals under 26 years of age, especially such as the teenage population. They're more likely to answer yes to this, other than just a flat out, do you have a problem with drugs or alcohol in the past, or have you been using? They're more likely to answer to these questions about normal everyday activities. So legal issues. So one of the reasons that we do not recommend the use of urine drug screens as a screening tool for illicit substance use in pregnancy is because of legal issues. And in ACOG, the American College of Obstetrics and Gynecology, recommends that as medical professionals that we advocate for patients, and we recommend the decriminalization of perinatal substance use. And this is really to promote adequate recognition and treatment. And here, nationally, there are 23 states and the District of Columbia consider substance use in pregnancy to actually be child abuse. And then 3 states consider it grounds for civil commitment. 24 states in the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure if they suspect drug use. So I did a little digging about Louisiana, and I found where Louisiana approaches this topic. And so we're going to talk about that. So they have approached this topic primarily in response to the national opioid epidemic. And they say that their approach to it is to address the needs of substance exposed newborns. And they do that in a multifaceted way, but they really primarily have 2 approaches. One, they define and address prenatal neglect and tell you the reporting mechanisms and the investigative protocols by the Department of Children and Family Services, DCFS or DHS or CPS, whatever you want to use for that. So they define prenatal neglect as any exposure to chronic or severe use of alcohol or the unlawful use of any controlled dangerous substance in any manner where it's not lawfully prescribed, and that this must result in symptoms of withdrawal in the newborn or the presence of the substance in the body of the newborn, and that or there are observable or harmful effects in the newborn's appearance or functioning. So they really do a good job of covering all bases here. So if you are aware that the mother used alcohol or any illicit substance and that it was not prescribed, or if the newborn or the mother have any symptoms or any presence of a controlled substance in their system, or say you don't have any presence or knowledge via a drug screen or meconium screen in the newborn, but you really suspect that this baby has NAS or neonatal opioid withdrawal syndrome NOWS, then you have to make a report here. And so if you do have to report, well, one, you have to order a toxicology test on the newborn without the parent's consent to determine if there is exposure. If the test results are positive, the physician must make a report of suspected prenatal neglect. So they're pretty clear here on what you have to do, and they cover a lot of their bases here with the law. Now, again, this is someone who is using illicit drugs or using chronic and severe use of alcohol throughout the pregnancy, and there are impacts on the fetus as shown. The next part is they address those individuals who are receiving opioids or medications for opioid use disorder under supervision of a medical provider. And by saying that, they say that you have a woman who's getting care, they're doing what they're supposed to do, but their fetus is exhibiting withdrawal symptoms because they are taking a legally prescribed medication in the appropriate way. You must fill out a physician notification form. And this does not constitute a report of child abuse or prenatal neglect, and it does not require in prosecution, but it does need to be done, and that does include a plan of safe care. And I found what that form looks like. And like I said, if you're listening to this, you obviously probably work in the substance use field, and so you have either heard of this process or you're familiar with it or you have seen this form. In Arkansas here, we have the law called Garrett's Law, and Garrett's Law states that if the mother or the child has any illicit substance in their system at delivery, then DHS has to be contacted, and DHS does an investigation. It does not differentiate between the appropriate prescribing and treatment of medications for opioid use disorder and illicit drug use. And it depends on DHS and the individuals in DCFS and how they interpret that. But they do have to do an investigation in these moms. So, woman admits to abusing opioids, asks for treatment. What is there to be done? So there are multiple options. You can do any of them. You can do all of them at any point. And we'll talk about what is recommended and what's not recommended, but there are multiple options. The first thing is nothing can be done. Maybe the woman's not interested in treatment, or she doesn't seek treatment or doesn't care to get treatment, so nothing can be done. One, patients could be medically assisted detoxed. So they could be brought into an inpatient setting and detoxed off of opioids. They could do inpatient or outpatient rehab. And then the other option is opioid agonist pharmacotherapy, which is also referred to as medication assisted treatment, or MAT, or more recently, medications for opioid use disorder is used. These terms are all been used recently. Some are out of favor, some prefer others. So who is the woman who requests medically assisted detox? Well, this is, I'll do a spoiler alert, evidence-based medicine does not support medically assisted detoxification in pregnancy. And the reason for this is there are high relapse rates later on. So in studies that took women and detoxed them during pregnancy, the relapse rates were 70% or higher at delivery for the use of opioids. So they have a high chance of relapsing and a high chance of going back to using opioids if they are detoxed. They also have an increased risk of overdose after being detoxed and then continuing to use. And that is because when you are detoxed or any period of detox, it resets your tolerance level for opioids, and patients are not used to that. So they go out thinking, well, I used this much in the past, I need that much now. And actually they don't. It also supports worse perinatal outcomes. So of course, any woman who has been detoxed and relapsed again, they're still in that cycle of actively having an opioid use disorder, and thus they are not getting treatment, going to their prenatal care visits, taking care of themselves, and this tends to lead to worse perinatal outcomes. If you do medically assist detox, or if you do detox in a medically assisted way of a woman, how do you do it? Well, there's no standard procedure. There's no evidence-based medicine or treatment guideline to do that. There's nothing that tells you have to do it inpatient or outpatient. I have done it both ways. I do prefer inpatient, and I almost always recommend inpatient if the patient is using heroin or fentanyl use, or if the patient is at the point of viability, which is the 3rd trimester or beyond. Some people will even say 24 weeks or beyond. It should be done in an inpatient setting with obstetrical consultation readily available. How do you do it? Buprenorphine or methadone, both can be utilized. Methadone taper is harder to do over time, but it's easier to initiate. And that's because buprenorphine requires the patient to go into slight withdrawal symptoms before they can take buprenorphine. With methadone, you can use it immediately. You do not have to wait for the patient to go into opioid withdrawal. But the taper of methadone is much longer. And so buprenorphine, we use the saying here at UAMS as 864 out the door. So they get 8 milligrams, followed by 6 milligrams the next day, followed by 4 milligrams the 3rd day, and then they are discharged. Methadone, you taper, you get a patient stabilized with no withdrawal symptoms, and then you have to taper them by a decrease of 15 to 20% every day, and that can take weeks. If a patient is medically detoxed, we almost always recommend that they go to inpatient rehab following their inpatient detox. And this is to make sure they are in a controlled setting that does not allow them access to opioids, as well as in a controlled setting that is not where other substance use is happening, and it's a healthy setting. And this is in my mind, the only option if a patient wants to be medically detoxed and they want treatment, is to follow it up with inpatient rehab. When you find an inpatient rehab, that can often be difficult. Here in Arkansas, we do not have a lot of facilities who are willing to take pregnant women, as well as pregnant women often have other children. And you have to find a facility that will allow them. You need to consider who's going to provide their pregnancy care. Is the facility going to be able to facilitate them going to their obstetrical appointments? If they deliver during treatment, are they able to go to the hospital, deliver, and then return to the facility with their child? Are they allowed? Who's going to take care of the child while they're in treatment, etc.? There's lots of things to consider. In Arkansas, we do have specialized women's services here, but even then, those services are often good quality, but low in quantity. So we just don't have enough beds for the amount of pregnant women we need to get into these beds. Inpatient rehab is often the best choice for a lot of patients. Patients who have failed opioid agonist pharmacotherapy, treatment with methadone or treatment with buprenorphine, patients who are, they get in treatment for opioids, so they get on methadone, they get on buprenorphine, they do really well, but they continue to use marijuana, they continue to use methamphetamine. Well, then really maybe the next step for them is inpatient rehab, because they're not able to kick the other substances. So oftentimes this is a good option for patients and needs to be considered where the patient is. So I have said opioid agonist, pharmacotherapy, medication-assisted treatment. Now the term most people like is medications for opioid use disorder. What is this? Well, simply it is a prescription of an opioid agonist, while at the same time the patient gets psychosocial services geared towards building a sober and recovery life. It is not just medications. and it is not just a support group. It is really the interplay of both. And for me, that's very important. So it's opioid agonist therapy. What does that do? Well, that prevents the opioid withdrawal symptoms that often lead patients to continue to use. Once a patient is stabilized on that, it has been shown over time to reduce the relapse to opioid use. It improves their adherence to prenatal care, and in turn, it will reduce obstetrical complications by improving adherence to prenatal care. And this is what the American College of Obstetrics and Gynecology recommends for all pregnant women with an opioid use disorder that is active. They do recommend medication-assisted treatment throughout pregnancy. We do, in medication-assisted treatment, you do inform patients about the risk of neonatal abstinence syndrome, and you look at it as a expected outcome of treatment and something the patient should be prepared about and they need to know. And this is a normal thing that occurs when patients take opioid agonist therapy. It also occurs when they are using illicit opioids as well. So it's not something that is a new risk, it's just a continued risk that we still expect. And then, of course, I'm a large component of counseling and behavioral therapy in conjunction with opioid agonist therapy. So they do have to get the groups and the individual therapy to work on the relapse prevention and rehabilitation and their ability to lead sober lives. In pregnant and postpartum women, this can also include parenting classes, prenatal care, or pregnancy information. It can be large and growing here. So there are two medications that are recommended for use in pregnancy, and one is methadone, one is buprenorphine. Methadone is difficult because it has to be given through federally licensed outpatient programs. It requires a woman to come 6 days a week, and they are just not readily available throughout many states. We have 3 here in the state of Arkansas and a large rural state. So we have a lot of people that don't live in Little Rock. They live throughout the rest of the state, so they don't have access to methadone. Buprenorphine is the largest, probably most common, and the easier access medication. Any provider, not just physicians, but APNs or PAs can get waived to prescribe buprenorphine for opioid use disorder. And so this has become more popular as a form for medication for opioid use disorder. So which one's better in pregnancy? Well, there was a large study done by Andre Jones called the Mother Study that compared women on methadone in pregnancy to women on buprenorphine in pregnancy. And it showed that buprenorphine use in pregnancy was associated with less treatment of medication, so less morphine for the babies who developed the NAS. It also had less length of stay in the hospital. So these babies stayed in the hospital less. They also received less days of treatment. So overall, buprenorphine was associated with a shorter hospital stay, shorter morphine use, and then shorter days of treatment as well. Now, methadone, however, had less treatment dropout. So a mother who was on methadone was more likely to stay in the program, but the infants on buprenorphine had better outcomes. This study led to many people starting to use buprenorphine during pregnancy and it becoming the cornerstone of treatment in opioid use disorder for pregnancy in conjunction with its easier access and availability. One of the new topics in this area in my world is, do we use buprenorphine, otherwise known as the generic Subutex, or do we use buprenorphine with naloxone, Suboxone? And in pregnancy, we have 2 rules of thumbs for the treatment in pregnancy. One, we use the least number of medicines possible. And in doing so, we historically use buprenorphine, because then the mom and the fetus are just exposed to buprenorphine, not exposed to 2 medicines like they would be in Suboxone. And so buprenorphine was traditionally chosen. However, as buprenorphine and buprenorphine with naloxone have become more readily available and the opioid epidemic has changed over time, more and more individuals are abusing buprenorphine on the streets here. So that has led a lot of people to want to use buprenorphine with naloxone during pregnancy. And outside of pregnancy, that is considered the gold standard due to the lower risk of abuse and diversion with Suboxone compared to just buprenorphine alone. And over the past 2 or 3 years, the amount of data supporting the use of buprenorphine with naloxone in pregnancy has been increasing, showing us that it is as safe, if not safer, than buprenorphine in pregnancy. So this has led to a lot of people that do what I do in pregnancy and postpartum specifically to actually start to use buprenorphine and naloxone only in pregnancy in favor and not use buprenorphine monotherapy. So a recent, the American Journal of Obstetrics and Gynecology, Maternal Fetal Medicine, so this is a high-risk journal by the American College of Obstetrics and Gynecology, published a meta-analysis in August of 2020 that looked at just under 2,000 mother and baby dyads, and they looked at babies who were on methadone, who were on buprenorphine alone, or who were on buprenorphine with naloxone, and they compared these groups, and they found 5 studies of 6 study groups, and it was a total number of less than 2,000 mom and baby groups. And they found that there was no serious adverse maternal or neonatal outcomes with buprenorphine and naloxone use. And they also found that individuals with buprenorphine and naloxone were less likely to require treatment for neonatal abstinence syndromes. The babies who got this medication were less likely to have neonatal abstinence syndrome. Now, they're not saying that buprenorphine and naloxone has a lower risk of NAS compared to buprenorphine. They actually believe that is because that lower risk was actually in comparison to methadone, not necessarily buprenorphine. So much like what we saw in the mother study. It's more of the comparison between methadone that gives you the lower risk for NAS than the comparison to the buprenorphine monotherapy. Okay. And I just realized we're running out of time. Okay, so I'm gonna run through this real quickly. Other things to know about opioid agonist therapy in pregnancy is we do recommend split dosing. So the way pregnant women metabolize medications differently. So there is data to support that buprenorphine should be prescribed twice a day in pregnancy instead of once a day. And then also there's also some data stating that in the 3rd trimester, you may need to increase the dose to get the desired effect. Other treatment options for opioid use disorder, naltrexone, of course, is becoming very popular for opioid use disorder, and it's a great option. However, we do not use it in pregnancy, and that is really because of the limited data, and we don't know its impact on pregnant women or their babies. Naloxone, of course, all pregnant women with an opioid use disorder should be aware of that, and it should always be used. And family members should also be informed of the use of naloxone, of when to use it, to have access to it, and when to seek help with the administration of naloxone. Neonatal abstinence syndrome, I've already talked about this earlier. I've kind of mentioned it in bits and pieces. A full discussion of this is a whole nother hour lecture. So we will just say that all opioid exposed babies should be monitored for this. And what is seen, well, it's really a constellation of central nervous system, GI, so belly problems, as well as sweating, low-grade fever, nasal stuffiness. Go there. The other thing I will say is that the one thing that has shown to decrease the risk of a baby having NAS and NOWS is if you can get a woman off smoke cigarettes. So if you get a woman on buprenorphine or methadone and you can get them to quit smoking, by the time they deliver, you lower the risk of their baby having NAS or NOWS. So smoking cessation should be offered to all women who are pregnant, as well as women with an opioid use disorder who are pregnant. Also in treatment, we need to address comorbid psychiatric illnesses. As you'll see here, 78% of our women had a co-occurring other substance use disorder in my clinic. Over half had major depressive disorder, and then just under half had PTSD. We also need to address their comorbid psychiatric illnesses with appropriate management in the treatment of their opioid use disorder. Breastfeeding is encouraged on medications as long as patients are not using opioids or other illicit drugs and there's no other indications. And at any time, if relapse occurs, breastfeeding should be immediately suspended. Postpartum care contraception is important. Just to put this out there, an average woman has 1.5 pregnancies in their lifetime. A woman with a substance use disorder has an average of 4 pregnancies in their lifetime. So the rates of contraception use are highly important here. Okay. And of course, I can't do with what I do without the support of my co-psychiatrist, my nurse, my peer support specialist, and my therapist. So I just want to give a shout out to them. They're not on here, but I want you to know these are some great people that I work with that allow me to do what I do. And I'm going to pause there. We're not going to get to the impact of COVID-19 in those slides, but I will share my slides if they want them, or to anybody who wants a copy of them. I do not mind giving them. And that's some data that we looked at on the impact of COVID-19 on our clinic in women who are getting buprenorphine and they are either pregnant or postpartum. So I am going to stop sharing and I will open it up for questions. Okay. So it looks like I'm getting lots of requests for the slides, and I can get that through the panels. Does anyone else have a question? Oh, here we go. I had someone say, why are urine screens not recommended? So urine drug screens are not recommended for the initial screening of a substance use disorder. So women coming into treatment or just women coming to their first prenatal visit and getting urine drug screened off the bat. And that's because many states have potential legal problems associated with positive drug screens. So the data's in here, but 3 states, if you come to your OB appointment and they get a urine drug screen and you're positive for marijuana, there are 3 states that consider that a criminal issue, and you can be locked up or go to jail or go to prison. So that is why it is not looked at. It's just not recommended at this time because there are potential legal consequences. And you can Google, there are multiple women out there who have been imprisoned because of substance use during pregnancy, which does not allow them to get the treatment that they get. It also discourages other women from getting treatment or from coming forward to actually getting treatment. They may want to, but they also don't want to go to jail. And so it prohibits them from coming forward and getting treatment. Okay, so it says mom on Subutex and baby has NAS, should they continue breastfeeding? Yes, so breastfeeding is encouraged as long, again, as mom is sober and not using any illicit substance and engaging in treatment, and baby is doing well. The act of nursing, not the breast milk or the medication that gets into the breast milk, but the actual act of nursing is very comforting and actually one of the treatments for NAS that is helpful. And that's what they often call kangaroo care or skin to skin. So you'll see moms and dads take their shirt off, baby gets naked, and they do skin to skin contact. Well, nursing and skin to skin contact is actually very soothing and a treatment for NAS. So yes, they should breastfeed then. Any reason why there is such limited research on naltrexone with pregnant women? Yes, because it's very hard to, the data right now, if someone comes to you with an opioid use disorder, you don't offer them naltrexone. So the only data that we have on women who get naltrexone during pregnancy are women who were already on it and then accidentally get pregnant. It's the same thing, I'll put it out there, like with the COVID vaccine. We all are aware that, well, should pregnant women get it? No. Should they? Yes. And the only data we had with COVID and pregnancy was the women who accidentally got pregnant while they were in the initial studies. And that's sort of the same thing with naltrexone, is you can't do a randomized trial in pregnancy because the answer is you always have to treat. And you're going to treat with the best known options that you have, which right now are not naltrexone. Most women I work with smoke weed, and when they deliver, DCFS, Division of Child and Family Services, is contacted. However, they are not offered treatment. I have to do that. So yes, marijuana use is becoming very, very popular in pregnancy. That's a whole nother slide, a whole nother presentation. In fact, many here in Arkansas, we have medical marijuana, and many of the dispensaries actually tout marijuana as a safe treatment for nausea in pregnancy. And it actually is not known to be safe and has not been studied for that in pregnancy. We do offer treatment in our program for marijuana use in pregnancy, and the majority of our referrals from the Division of Child and Family Services is for cannabis use disorder in pregnancy or for marijuana positive in pregnancy. But yes, I think a lot of people don't recognize the severity of cannabis use disorder that we have here in the United States globally. Not saying that everyone who smokes marijuana has a problem, but it definitely is more common and often downplayed due to the media and the legalization of marijuana that we're seeing throughout the nation. Okay. Pregnant female in third trimester on Subutex. Her OB-GYN is aware that she's on MAT. Should she inform pediatrician? So yes. So what we do in our program, in the group therapy we have the neonatologists or the pediatricians from the hospital side actually come over once a month and talk to the women in our groups and answer all their questions about it. But their pediatrician also needs to know, especially if they're breastfeeding, as well as to observe observe signs for NAS, neonatal abstinence syndrome. Because a lot of times here in our hospital, they're discharged at 72 hours after delivery, but the baby actually may not start to exhibit signs until after that. So there needs to be close follow-up, and someone needs to lay eyes on baby to see if there are any effects and if the baby may need to come back to the hospital. Mom on Subutex usually cut the dose. Reason on for that. To cut the dose, I'm not sure I know what that means. Now, if you mean half the dose, so usually our moms who buprenorphine, we split the dose. So if they normally take 16 milligrams a day, we tell them to take 8 milligrams in the morning and 8 milligrams at night. There's no reason to lower the dose. And multiple studies have looked at dose of Subutex and the risk of a baby having an NAS, and there is no correlation. One mom can be on 16, one mom can be on 8, one mom can be on 32 milligrams, and their babies have the same risk of NAS. Do we know the long-term effects of NAS? No, I had a slide on, no, we don't. Again, that's another topic, but is starting to be looked at. The study that I mentioned here that UAMS is part of with the Children's Hospital here is looking at that, but that studies are just being done. What's the endpoint of detox? For me, the endpoint of detox would just be if the woman does not want to be on medication assisted treatment because it hasn't worked in the past, or because they have an allergic reaction and they want to get treatment and they want to be sober, and they go to rehab, inpatient rehab. So in my mind, detoxification is only an option if the woman also says, I do want to go to inpatient rehab, where they're in a consistent, controlled environment and can get that established support system and work on that rehabilitation and ability to get back into the community as a sober individual. I hope that answers your question. All right. We are 3 minutes over. I don't want to cut anybody off, but I also want people to be able to get back to whatever they're doing. I am open to people emailing me questions, and I'm also open to giving y'all a copy of my slides, and y'all are free to share those with people if you need them.
Awesome. Thank you so much, Dr. Ray. That was very informative. And yes, I saw a lot of requests for those slides. So I will email those out to everyone in attendance. If Dr. Ray, you have one that you want to share, you can email that to me, or is the one that you had sent earlier,
Okay.
I'll just send out. Again, I want to remind everybody, if you did watch or listen into the presentation using your phone, you dialed in, please email me at ashley@womansfoundation.com, your first and last name and the phone number you use to dial in so you can get your certificates. And we'll send that out to you in the next few days. So thank you so much. We're about 4 minutes over, so sorry for keeping everybody. Hope everybody has a good rest of the Wednesday. Bye, everybody.